Okay. Good evening, all. Welcome to IRIA Kerala PG Gastrointestinal Case Presentation Series in association with JournoMed. And after hepatobiliary, now we are entering into the gastrointestinal section. And this is the first session. And today it is the PG presentation. And in this context, I heartily welcome Dr. Gomati Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, Dr. Ramesh Shenai, Program Coordinator. And today the program is actually convened by our faculty, Dr. Aditi P. She is consultant radiologist, BPS Lakeshore Hospital, Kochi. And this is being moderated by Dr. Tara Pradap, Head of the Department, BPS Lakeshore, Kochi. And welcome to Dr. Aditi and Dr. Tara, and also the residents, Dr. Sruthi Babu and Dr. Amrita Aravind. They are also from Lakeshore, Kochi. And now, for opening remarks, over to Dr. Gomati Subramaniam, President Kerala IRIA.
Thank you, Dr. Venu, our chairman of academic session. As already said by Dr. Venu, we are in the 4th month. We have finished our chest series, cardiac series, and hepatobiliary series, and now we are entered into the gastrointestinal tract, which is very, very useful for our residents because most of the long cases come from the GIT. So it will be a very useful session. So we are starting with the discussion with our residents along with Dr. Aditi. Dr. Thara will be introducing Dr. Aditi. Thank you. All the residents, be attentive throughout this 1 hour session. Thank you.
So, very good evening to all. Am I audible?
Yes.
Very good evening to all. So today we have 2 case presentations by 2 of our PGs, Dr. Amrita and Dr. Shruti. And the faculty for today's session is Dr. Aditi, who is an enthusiastic academician from Lakeshore Hospital and who has done her fellowship. So I invite you to this session. Dr. Aditi, please, and I think Dr. Amrita can start with her presentation. Over to Dr. Amrita.
Good evening to all. I'm Dr. Amrita Aravind, Secondary DNB resident, BPS Lakeshore Hospital, Kochi. Today we are going to discuss a case of gastric outlet obstruction. Next slide, please. So this is a 22-year-old male patient who was evaluated with history of early satiety and loss of appetite for 6 months duration. And there was also history of significant weight loss. No history of constipation, abdominal pain, vomiting, melena, or jaundice. And he came to our hospital for further evaluation. Next slide. So initial blood investigation were within normal limits, and upper GI endoscopy was done, which showed duodenal ulcer with gastric outlet obstruction. And further CCT scan of the abdomen was done. So these are the images of axial plane CT sections of the abdomen. You can see there is a distended stomach with oral contrast. There is diffuse circumferential wall thickening of the antropyloric region and the duodenal cap. And rest of the stomach wall was appearing normal. Next slide, please. This is the arterial phase images, axial sections, again showing the distended stomach and diffuse circumferential wall thickening of the antropyloric region with a deformed duodenal cap. Please scroll down, please. Please scroll down. Down. Let's scroll down. Stop. So there are also, again, this is the axial contrast CT section, portal venous face, again showing the same finding of a distended stomach and thickening of the antropyloric region and duodenal cap. And there are also multiple enlarged peripancreatic, iotocaval, and paraortic lymph nodes. You can scroll down. So there are multiple lymph nodes in the retroperitoneum. Down. Down. And also enlarged lymph nodes in the mesenteric root. And rest of the small bowels appeared normal. And there was no evidence of any liver lesions. Spleen was bulky. There was no any liver lesions or ascites. Scroll down. Down. No. Previous slides. Again, previous. Stop. So this is the coronal section showing the ileocecal junction, which also appeared normal. And next slide. So these are the four phases, the plain CT section, the arterial and venous phases, showing the distended stomach and diffuse thickening of the pyloric antrum and the duodenal cap with the deformed duodenal cap. Next slide. And there are multiple paraortic, peripancreatic, iotocaval lymph nodes, and few of the lymph nodes show evidence of necrosis also. Next slide. So to sum up, this was a 22-year-old male patient presented with weight loss and was evaluated and found to have circumferential thickening of the antrum with a distended stomach and partial gastric outlet obstruction with regional and retroperitoneal lymphadenopathy. Next slide. So the differential diagnosis considered are antral malignancy with lymphadenopathy, peptic ulcer disease, and other differential diagnoses included gastric lymphoma, granulomatous etiology like tuberculosis or Crohn's disease. Next slide. So this patient underwent endoscopic biopsy from antrum and duodenum and yielded only H. pylori gastritis, and there was no evidence of any malignant cells. And in view of diffuse wall thickening of the antrum and multiple lymph nodes, he was taken up for surgery. Next slide. So the intraoperative findings included a dilated stomach with edematous gastric wall, and there were multiple perigastric lymph nodes. And frozen section of the perigastric lymph node showed evidence of a caseating granulomatous change. And gastroduodenostomy was performed to relieve gastric outlet obstruction. Next slide. And final histopathology from the perigastric lymph node showed caseating granulomatous lymphadenitis, which features are in keeping with tuberculosis. Next slide. So coming to discussion. So the causes of gastric outlet obstruction in adults are broadly classified into intrinsic causes and extrinsic causes. So concentrating on the intrinsic causes due to bowel wall pathologies, it is classified into benign and malignant causes. The benign causes included peptic ulcer disease, NSID strictures, tuberculosis, adult hypertrophic pyloric stenosis, Crohn's disease, and malignant causes include adenocarcinomas, lymphoma, rarely metastasis, and GIST. And others included tumors and tumor-like conditions like adenoma, lipoma, carcinoids. And the intrinsic causes due to intraluminal pathologies like foreign body, gastric bezoar, Beverage syndrome. And few of the extrinsic causes, benign causes included acute pancreatitis, pancreatic pseudocyst, annular pancreas, diaphragmatic hernia. Malignancies included pancreatic neoplasms, GB and biliary malignancies. Next slide. So peptic ulcer disease has been the most common cause of gastric outlet obstruction, but due to increased prevalence of endoscopy and anti-H. pylori drugs, in present day scenario, gastric malignancy is the most common cause of gastric outlet obstruction. In Western countries, the gastric cancer also has significantly reduced due to low prevalence of H. pylori. And in these countries, pancreatic cancer is now the most common cause of gastric outlet obstruction. So coming to acute peptic ulcer disease on CT scan. So ulcers in peptic ulcer disease are usually not demonstrated on routine CT studies unless they are deep or have penetrated or perforated the gastric wall, or the site of involvement may be identified as perigastric fat stranding. Next slide. So on imaging, the features helpful in differentiating peptic ulcer disease and malignancies include, in a case of peptic ulcer disease, more or less symmetric hypoattenuating pyloric duodenal mural thickening corresponding to submucosal edema can be seen with interrupted mucosal enhancement or outpouching through the wall, and without any associated solid tissue adjacent to the ulcer, and with associated inflammatory stranding of the surrounding fat. And in the case of malignancy, it's usually an asymmetric, irregular pyloric duodenal thickening, and usually does not protrude beyond the gastric contour. And there will be an associated soft tissue component seen, and with regional lymph nodes also. Next. So we have discussed about the acute peptic ulcer disease, but in the case of chronic duodenal ulcer, even the submucosal edema and perigastric stranding may not be visualized on CT, and it may be only evident. There will be only evidence of any deformed duodenal cap with evidence of gastric outlet obstruction. So this was a case due to a chronic duodenal ulcer causing gastric outlet obstruction. So role of barium study. Gastric ulcers can be detected on multiple imaging modalities, but are best evaluated on a double contrast barium study. Next. So these are the images of a benign gastric ulcer, double contrast barium study images. So you can see there's a smooth, deep ulcer with a smooth margins and smooth ulcer mound, and the smooth gastric folds reaching up to the ulcer margins. And you can see the ulcer is protruding beyond the gastric contour. Next slide. And Hampton's line is a sign seen in a benign gastric ulcer. And this is a thin radiolucent line that separates the barium in the ulcer crater and also from the barium in the gastric lumen, which is seen in benign gastric ulcers. Next slide. So malignant ulcers, usually it will be irregular shallow ulcers with nodular margins, and the gastric folds usually doesn't reach up to the ulcer margins, and usually it is endoluminal and it doesn't protrude beyond the gastric contour. Next. And one of the signs which can be visualized in a malignant ulcer is a Karman meniscus sign. This is the lenticular shape of the barium which is seen, and the inner margin is convex towards the lumen, which is seen in a malignant gastric ulcer. So these are the features on a double contrast barium study to differentiate between a benign and a malignant ulcer. Benign, the outpouching of the ulcer crater beyond the gastric contour can be seen with a smooth rounded ulcer crater with a smooth mound and the smooth gastric folds reaching up to the margin of the ulcer, and Hampton's line may be visualized. Whereas in a malignant ulcer, it usually does not protrude beyond the gastric contour, and the irregular and shallow ulcer crater can be seen with a nodular mound and gastric folds that doesn't reach up to the ulcer margin, and also Karman meniscus sign, which favors a malignant gastric ulcer. Next. Coming to the next entity, that is tuberculosis. Gastrointestinal tuberculosis is most often occurring in ileocecal region. So the order being ileocecal junction, more than jejunal, followed by colon, and lastly esophagus, stomach, and duodenum. Localized duodenal tuberculosis is extremely rare, occurring in 1 to 2% of abdominal TB cases, and more commonly it occurs secondary to pulmonary disease. And this is due to high acid content, rapid gastric transit time, and lack of significant lymphoid tissue in gastric mucosa. So in gastric tuberculosis, the disease may affect the duodenum either by an intrinsic process or an extrinsic compression. So extrinsic compression is more common than intrinsic involvement, and it is due to the enlarged lymph nodes. And intrinsic involvement may be an ulcerative or a hypertrophic. So intrinsic in hypertrophic type of intrinsic involvement and extrinsic compression, in these cases, it can present as a duodenal obstruction. Next. So on imaging duodenal TB, we can visualize strictures and extensive compression due to lymph nodes. It can be a pulpoidal mass, ulcers, and also complications like perforation or fistula. So another granulomatous etiology is a Crohn's disease. So inflammatory bowel disease that may involve any site of the GIT with predilection for terminal ileum and proximal colon. So even in Crohn's disease, gastroduodenal involvement is rare and it seldom occurs in isolation. And usually the antrum pylorus and proximal duodenum are involved in a contiguous manner. Next slide. And in Crohn's disease, it can be a primary involvement or a secondary involvement. So primaries can manifest as an ulcer or stricture formation in the stomach and duodenum, leading to gastric outlet obstruction. Whereas secondary, the disease in an adjacent small bowel can extend via fistulous communication. Next slide. So on barium studies, Crohn's disease manifests as an aphthous ulceration, cobblestoning, rugal fold thickening, pseudo-diverticular strictures, which are also visualized in endoscopy. Next. So coming to malignancy. So adenocarcinomas, that is gastric, duodenal, and pancreatic, primary biliary tumors, and less often lymphomas are the malignant lesions affecting the gastroduodenal region, causing outlet obstruction. Next. Next. So this is a case of adenocarcinoma in the region of antropyloric region causing gastric outlet obstruction. You can see there is irregular circumferential thickening of the antropyloric region causing a gastric outlet obstruction with a distended stomach. So gastric adenocarcinoma on CT scan, it can present as a focal or diffuse, nodular or irregular mural thickening, or an ulcerative mass or polypoidal mass, and with associated local lymphadenopathy and evidence of metastasis. Next slide. So lymphoma, gastrointestinal lymphoma commonly involves the stomach, and they are the non-Hodgkin's lymphomas of basal origin. And it can range from a low-grade myeloma to aggressive diffuse large B-cell lymphomas. Next. So on imaging, the features which are helpful in differentiating adenocarcinoma and gastric lymphoma includes, in the case of adenocarcinoma, the mural thickening is usually less than 1 centimeter, whereas the mural thickening more than 1 centimeter points towards gastric lymphoma. And irregular outer contour is usually seen in adenocarcinoma, whereas a smooth outer contour favors gastric lymphoma. And multifocal lesions and transpyloric extension is rare in case of adenocarcinoma, where this can be seen as a common manifestation of gastric lymphoma. And obstruction is common in adenocarcinoma, whereas it is rare in gastric lymphoma. And enlarged lymph nodes, usually suprarenal region, it favors adenocarcinoma, whereas extension of lymph nodes in the infrarenal level, it favors gastric lymphoma. So these are the images. It's an image of gastric adenocarcinoma. There is an irregular thickening of the distal body and antropyloric region of the stomach. And these are the images of gastric lymphoma, where there is circumferential thickening of the stomach wall with a smooth outer contour. And mural thickening is more than 1 centimeter in a case of gastric lymphoma. Next slide. And rarely malignant GIST can also manifest as a gastric outlet obstruction. Next slide. So this was one of our cases where there is a heterogeneously enhanced lobulated mass in the region of first part of duodenum, which also shows areas of ulceration and causing a partial outlet obstruction. There was also cystic metastasis in liver also. Next slide. And very rarely, adult hypertrophic pyloric stenosis is a benign cause causing gastric outlet obstruction. Usually, this is seen in children where there is a smooth thickening of the pylorus. And here you can see the cervix sign, that is smooth thickening of the pylorus of the stomach with gastric outlet obstruction. Next slide. So, a few of the extrinsic causes causing gastric outlet obstruction. First one is a groove pancreatitis. So groove pancreatitis, the features include a thickening of the duodenal wall with or without duodenal stenosis, and fibrous tissue with fibrous tissue within the pancreaticoduodenal groove, and CVD dilatation. So this was a case of groove pancreatitis. There is thickening of the duodenal wall with duodenal stenosis, and there is inflammatory changes and fibrous tissue in the pancreaticoduodenal groove. Next slide. So the coronal images showing the thickening of the duodenal wall with narrowing of the duodenum and inflammatory changes in the pancreaticoduodenal groove with gastric outlet obstruction. It's a distended stomach. Next slide. So another cause of extrinsic compression causing gastric outlet obstruction is the annular pancreas. So here you can see there is pancreatic tissue encircling the second part of duodenum with gastric outlet obstruction. And next slide. A few words about annular pancreas. So normally the pancreas, by the fourth week of embryologic development, pancreatic duct develops from separate ventral and dorsal buds originating from the endodermal lining of the duodenum. And the ventral ducts give rise to gallbladder, extrahepatic and intrahepatic bile ducts, and the ventral pancreas with its ductal network. Next slide. And the dorsal bud is the precursor to dorsal pancreas and its ductal system. Next slide. So this is the image showing a dorsal bud and the ventral bud. Next slide. So by the 7th week of gestation, the ventral bud rotates clockwise posterior to the duodenum, and it undergo fusion with the dorsal duct. Next slide. Next. And the pancreas is developed normally. Next slide. So incomplete rotation of the ventral enlarge leads to the segment of pancreas encircling the second part of duodenum. So this is an incomplete annular pancreas. Next slide. Image showing complete annular pancreas. So next slide. It can be complete or incomplete annular pancreas. In complete annular pancreas, it completely encircles the second part of duodenum. Next slide. So this is a barium image showing a smooth narrowing of the second part of duodenum. This was a case of complete annular pancreas, which causing duodenal obstruction. Next slide. So this is another case of large cyst in the region of head of pancreas, which caused partial gastric outlet obstruction, possibly a pancreatic pseudocyst, causing a gastric outlet obstruction. So to conclude, we dealt with the common causes of gastric outlet obstruction in adults, and our case was a rare cause of tuberculosis causing gastric outlet obstruction with tubercular lymphadenitis. Thank you.
Dr. Amrita has dealt with almost the entire spectrum of cases causing gastric outlet obstruction. So any comments, questions are welcome, and over to Aditi for her comment.
Okay, so good evening all. So Dr. Amrita discussed in detail about gastric outlet obstruction. Now, gastric outlet obstruction is an important PG topic, especially the exam point of view. It can be your short case, long case, it can be your viva. So you need to know in and out about gastric outlet obstruction. So regarding the approach to gastric outlet obstruction, first is this slide itself shows there is a wide spectrum of causes responsible for gastric outlet obstruction in adults. It can be intrinsic or extrinsic. It can be benign or malignant. So even though proton pump inhibitors have reduced the incidence of peptic ulcer disease, it is still the most common cause of benign cause of gastric outlet obstruction. And among the malignant causes, we have gastric cancer as the most common in India. But in Western literature, they say pancreatic cancer is the most common. So and we have a long list of malignant and benign pathologies and intrinsic and extrinsic causes responsible for gastric outlet obstruction. Now, how do we radiologically approach a case of gastric outlet obstruction is another important point. So, Amrita, are you here?
Yes, ma'am.
Okay. So, what will you expect in an X-ray in a case of gastric outlet obstruction? In a plain X-ray?
The next day, there will be an enlarged gastric bubble seen in an abdominal radiograph.
Abdominal radiograph, and there might be some mottling within that gastric bubble due to the air entrapped within the retained food particles. But usually an X-ray won't contribute much to the cause of gastric outlet obstruction. And probably, what is Beverage syndrome, Amrita? So Beverage syndrome is actually an ectopic gallstone located within the stomach, pyloroanteric region. So sometimes in X-ray, we can see it's actually a kind of gallstone ileus, a proximal kind of gallstone ileus. So here we can see an ectopic gallstone located in the pyloroanteric region. There will be pneumobilia. Sometimes that can be detected in the X-ray. Okay. So then coming to the barium. So she has discussed in detail the barium findings of malignant and benign ulcers. So barium is not routinely used nowadays, but still the double contrast barium studies can characterize the benign and malignant ulcer very efficiently if done properly. So, and it can differentiate between the partial and complete obstruction. And then coming to CT. So CT is usually the first and the most important modality used in gastric outlet obstruction. That shows the location of thickening. We can characterize the wall thickness. We can rule out the intrinsic and extrinsic causes of obstruction. We can assess pancreas, biliary tree, and other associated lymphadenopathy. Okay, so that is the role of CT. So as far as gastro people are concerned, endoscopy is the gold standard because that helps in, so can we say partial and complete obstruction? So partial obstruction means some contrast will pass through the stomach into rest of the small bowel. Complete obstruction means it will remain only in the stomach. So that is how we call it partial and complete obstruction. Then, so coming to the endoscopy, so that is a gold standard for gastro people because that helps in diagnostic and therapeutic characterization. Another important point is, Amrita, is there a role of nuclear medicine? Amrita, are you here?
Yes, ma'am.
Okay, is there a role of nuclear medicine in gastric outlet obstruction? Okay, you are not expected to answer this, but just for the completion's sake, there is an entity called gastroparesis. So in gastroparesis, patient will come with all the symptoms of gastric outlet obstruction, but we won't be able to see any mechanical obstruction with any of the modalities. So then there is a delayed gastric emptying without mechanical obstruction or gastric paresis. So how can we objectively quantify this gastroparesis? For that, we use gastric scintigraphy techniques. So in scintigraphy, we make the patient take egg scramble, which is labeled with technetium 99 sulfur colloid, or we make them drink water labeled with indium 111. Okay. So, and then series of sequential images are taken at 1 hour, 2 hour, and 4 hour. And another important question for your exam is, when do you call delayed gastric emptying? Amrita, any idea? Amrita or anyone can contribute. Okay, so delayed gastric emptying is when actually what we expect is at the end of 1 hour, only 10% of the initial food crosses the stomach. At the end of 2 hours, we expect approximately 50 to 60% of the food to leave stomach. At the end of 4 hours, only 10% of the initial food should be left behind in the stomach. So at the end of 4 hours, if we are seeing more than 50% of the initial food taken, then we can call it a delayed gastric emptying. Okay, that is applicable in barium studies also. So if that is the case, then we call gastroparesis. And there are various causes of gastroparesis. So even if we are not able to find a cause of mechanical obstruction with these imaging modalities, then that could be gastroparesis secondary to diabetes or previous radiation therapy or any other infiltrative disorders like sarcoid, amyloidosis, or connective tissue disorders. Okay. So now coming about now in small discussion on gastroduodenal TB. It's a rare entity. Primary gastroduodenal TB is even more rare. It's only 0.5%. So secondary gastroduodenal TB occurs secondary to pulmonary TB or an ileocecal TB. And it's again very rare. It's approximately 0.5 to 2% out of the total gastrointestinal TB. And so a high index of suspicion is required to raise the possibility of gastroduodenal TB. In our case, the patient was only 22 years. And there was diffuse gastric thickening with weight loss. And there were multiple necrotic nodes everywhere. So that prompted us to think about a cause other than malignancy. And we gave the possibility of granulomatous etiology. And so simultaneously, if we raise the possibility of TB, another advantage is that the gastro people, when they do endoscopy, well, they will take deep biopsies. The issue is many a times they take just superficial biopsy. So the chance of missing the diagnosis of tuberculosis etiology is more, because these caseating granulomas are located mainly in the submucosal plane or deeper. Only if we raise the possibility of gastroduodenal TB, they might take a deeper biopsy. So biopsy with PCR and culture is the gold standard in diagnosing gastroduodenal TB. Always suggest pulmonary chest CT or X-ray and to look for any primary TB elsewhere. Also look at ileocecal region. Rule out pod spine associate, which might be the primary locations for TB. And and what is the management of gastroduodenal TB? So gastroduodenal TB is basically treated with ATT. So antituberculous treatment for 4 months can relieve most of the symptoms. Especially if required, they may do endoscopic stenting or balloon dilatation. And usually they go for surgery only if these treatment modalities fail. So if we don't give a diagnosis of granulomatous etiology or TB in one of our differentials, probably they will go for surgery and unnecessary surgery directly. So that is another importance of raising the possibility of gastroduodenal TB in appropriate scenario. In our case, surgery was done mainly because the patient was acutely symptomatic. So in such cases, again, that is the only indication for gastrojejunostomy in a gastroduodenal TB. So that is in short about gastric outlet obstruction and gastroduodenal TB. So any more questions?
Any comments, Gomati ma'am? Anything more to add on to this? Gomati ma'am? Dr. Venu sir? Venu sir?
Yeah, I think yes, almost complete. All points were touched, and this is very rare case, of course. The granulomatous disease involving the pyloric antrum and all, very rare. Now, just one point I would like to add. When somebody describes about the lymph node, so it's better to describe the lymph node a little more with you add some adjectives and all. One thing, how can you define a node? Suppose in the presentation node, suppose you one wants to tell about node. So you can get nodes in the cervical region or in the axillary region or mediastinum or the retroperitoneum, perigastric and all. So how will you describe a node, or how can you define a node? Or when one can say that this is node? So that is very important now. So ideally, if you are telling like that, see, when you can say confidently that it is a node, if you are seeing a node in the location where a node is expected to be seen. Okay, then you can say that this could be a node. So otherwise, the same thing is seen somewhere else. For example, in the paranephric space, then you cannot put it as a node. Or if it is seen in a subcutaneous plane, then you cannot put it as a node. So when a spherical structure, a spherical nodule, or an oval-shaped nodule is seen, soft tissue dense nodule is seen in the location where a lymph node is usually expected to be seen, consistent with the node. Okay, so like that you can just, if you put it like that, it would be, I think, it will give a better picture now. So here you can say that suppose retroperitoneal nodes are there. There are multiple well-defined round or oval shape soft tissue dense nodules with smooth outline measuring this much centimeter or millimeter in short axis in the retroperitoneum or in the perigastric region where lymph nodes are expected to be seen consistent with lymph nodes. Okay, and also you can add a word as it was given in this description now, like necrosis. Actually, that is very important. So central necrotic area or central cystic area is very important. So when you see a node with a central necrosis or central hypodense area, then immediately some 2 or 3 things should come into your mind. One is granulomatous disease, of course. And second is metastatic disease. So from which metastasis, from which primary? Squamous cell carcinoma. So squamous cell carcinoma with the primary, with the metastatic nodes can have central hypodense area. Okay. And third one, what you can call germ cell tumor. Okay, germ cell tumor are basically the metastatic germ cell tumors are hypodense or cystic, even cystic. You can very well appreciate the cystic nature of the nodes now. So when you see a cystic node, it's not necrotic node, a cystic node, because the entire node is actually cystic, so fluid dense. Cystic node, then most probably the primary would be germ cell tumor. So you have to search for either ovary or testis or even mediastinum. So like that, the description of the lymph nodes and also bulky nodes. Bulky nodes again more in favor of lymphoma. Then whether calcification is there or not. Okay. So all these adjectives you can give when you describe a lymph node. Okay, thank you.
So thank you, Dr. Aditi and Dr. Venu for that excellent summing up on gastric outlet obstruction. I think there are
one question, just one question for the resident. She was telling about the annular pancreas, which causes gastric outlet obstruction, isn't it? Also, the resident, she's online. Can you tell me one? She's online, isn't it? Can you tell me one procedure where you can expand the second?
Sorry, ma'am.
Can you tell me one procedure where you can expand the second part of duodenum or dilate the second part of duodenum to confirm it is an annular pancreas? It's related to a procedure that is mainly barium for you, and you add something into it to distend it.
You can give
this procedure is not done nowadays. It was done before the era of our new technologies. Got it? Got it?
We can give
just for completion's sake.
You can add anticholinergics like buscopan to distend the small bowel.
Very good, very good, very good. So it will expand it and you can confirm. How do you say definitely it is annular pancreas? Conventionally. Conventionally. Yeah.
There is a smooth narrowing of the second part of duodenum due to extrinsic compression.
Where? Laterally or medially?
Laterally.
on the right side of the duodenum, isn't it? Right
Yes.
lateral part of the duodenum, you will have a indentation that indicates it is a annular pancreas. That was the previous teaching. Now we have CT, which helps us to give the diagnosis, isn't it? Okay,
Yes.
thank you. You can carry on.
Thank you.
I think now we'll move on to the second presentation.
Hypotonic duodenum.
And I welcome Dr. Shruti to do the presentation.
I'm Dr. Shruti Babu, post-diploma DNB resident, VPS Lakeshore Hospital, Kochi. Next. Next slide. Next slide. Okay. So I'm presenting a case of a 68-year-old female presented with abdominal pain, bloating sensation, vomiting, and diarrhea. And the patient was evaluated and came with a CCT abdomen done outside. And she was referred here for a PET-CT scan and for further evaluation management. Next. So these are the axial sections through the upper abdomen at the level of liver in arterial phase. You can see multiple arterial phase enhancing lesions in the liver, in both lobes of the liver. So coming to the venous phase. Next slide. Okay, please scroll. These are the axial images of the CCT abdomen in venous phase. We can see, please scroll. Stop. We can see the previously enhancing lesion in the liver has become iso to hypodense in venous phase. Please scroll. Scroll. Okay, stop. And we can also see an incidental finding of a calcified foci in right lobar liver, maybe a calcified granuloma. These are the hypodense. These are the lesions in the liver which was hyperintense in arterial phase imaging. Please call. The bilateral adrenals, bilateral kidneys, and the spleen were normal. No focal lesion was there. And please close. Stomach and the proximal bowel loops were also normal. No evidence of any bowel wall thickening, no focal lesion. Please scroll. Pancreas was also normal. No evidence of any focal lesion. The abdominal aorta and its branches. Please scroll down. Down. So stop. We can see. Please scroll above. One slide above. Okay. We can see enhancing lesion in the distal small bowel. One is here. Down. One is here, and scroll down. One is here. Please scroll. So stop. This is a novel soft tissue enhancing lesion in the mesentery at the root of mesentery with radiating strands, giving a spiculated appearance. And scroll. There is no evidence of any calcification seen within, and the adjacent small bowel loops are clumped together, and there is edematous faulting. Please scroll. There is bowel wall obstruction and any signs of bowel wall ischemia. No free fluid is seen in the abdomen. Please scroll. Down. In the pelvis, we can see this is an endometrial collection, incidental finding, and please scroll down. There is an incidental finding of a right adnexal cyst. Please scroll down. Okay, so this is an enhancing soft tissue lesion in the pouch of Douglas. Okay, stop. The pelvis and the thoracolumbar spine appears normal. No evidence of any lesion except for the degenerative changes. Scroll, please. Scroll. Okay, previous slide. Next slide. Okay. So to sum up, the CECT abdomen findings were there were multiple enhancing rounded small lesions in the distal ileum with clumping of the bowel loops and along with bowel wall thickening. And there were enhancing mesenteric lesion. There was an enhancing mesenteric lesion with surrounding desmoplastic reaction. Thickening of the mesenteric folds with congested mesenteric vessels. Multiple arterial phase enhancing lesions in the liver, an enhancing nodular deposit in the pouch of Douglas, and an incidental node of right adnexal cyst. Okay, the patient was taken for gallium-68 DOTA PET scan. The whole body PET scan was taken 60 minutes after the IV injection of the 5 millicurie of gallium-68 labeled DOTA. Next. We can see multiple DOTA avid lesions in both lobes of liver. These are the DOTA avid lesions, which corresponds to the hyperenhancing arterial lesion in the CT scan. Next. Okay, we can also see multiple DOTA avid lesion in the small bowel and also the mesenteric lesion with desmoplastic reactions also. Next. The pouch of Douglas lesion was also showing DOTA avidity. Next. So the PET report came as multiple somatostatin receptor expressing nodular enhancing lesion in small bowel loops, likely a multifocal small bowel neuroendocrine tumor. The somatostatin expressing receptor expressing enhances soft tissue lesion in mesentery with surrounding desmoplastic reaction, suggestive of metastasis. Then somatostatin receptor expressing enhancing nodular soft tissue lesion in pouch of Douglas, suggestive of metastasis, and multiple somatostatin receptor expressing nodular lesion in both lobes of liver. Then the laboratory findings came as elevated 5-hydroxyaminoacetic acid in 24-hour urine sample and elevated chromogranin A. So combining the clinical profile and the imaging findings and the laboratory values, we came to the diagnosis of multifocal gastroenteropancreatic neuroendocrine tumors, which is a newer term for carcinoid tumor of ileum with metastatic deposits in mesentery, liver, and pouch of Douglas. So the patient underwent a laparoscopic liver metastasectomy with open ileocecal resection, and the histopath showed well-differentiated neuroendocrine tumor of grade 2, and started on systemic therapy with octreotide. And now she's on follow. So these are the post-op images, axial section at the level of liver in arterial phase. We can see few lesions are still showing enhancement. That is, this represents the residual metastatic lesion in the liver. Next slide. So after the ileocecal resection, there is no evidence, and there is complete resection of the mesenteric mass and the ileal small bowel primary carcinoids, and no enhancing lesion is seen here. And there is also no evidence of any bowel wall thickening or any other signs of ischemia like that. However, we can see an enhancing lesion in the pouch of Douglas, suggesting that it's a residual lesion. So coming to the differential diagnosis, differential diagnosis of mesenteric spiculated mass includes sclerosing mesenteritis and the desmoid tumor. Next. Coming to sclerosing mesenteritis, it's a rare condition of unknown etiology, and it is characterized by mesenteric inflammation, fibrosis, and variable amount of fat necrosis. It may show calcification. So mesenteric sclerosing mesenteritis occurs in 3 stages. The first stage is the mesenteric panniculitis, in which there is chronic inflammation. So we can get a focal increased increased density of the mesentery, known as misty mesentery sign. And a next stage is the mesenteric lipodystrophy, where fat necrosis occurs. Later in the chronic stage, fibrosis occurs. that is the Sclerosing Mesotheitis stage. So this coronal image showing a soft tissue lesion at the root of mesentery with multiple calcifications seen within, and there is surrounding fast standing fibrotic kinking and traction from the traction over the small bowel loops. This is a case of Sclerosing Mesotheitis. Now, coming to desmoid tumor. Desmoid tumor are locally aggressive, non-encapsulated masses resulting from a benign proliferation of fibrous tissue. They can occur sporadically or in association with familial adenomatous polyposis. When they occur in association with FAP, there will be APC gene mutation. So this is an image taken from Goran Levin, a textbook. We can see a soft tissue, irregular soft tissue lesion with fat stranding and a little kind spiculated appearance, stellate appearance. Next. This is one of our cases. This patient underwent total proctocolectomy for familial adenomatous polyposis coli, and the follow-up CT image showed a soft tissue lobulated mass in the mesentery. In the right lower lumbar region, and there is encasement of the mesenteric vessels at that level. So for desmoid tumors, there is factors include any prior trauma or surgery. There is an association with estrogen, so it can be seen in pregnancy or oral contraceptive use. The imaging findings include the CCT can be the lesion can be ill-defined to well-defined, and the characteristic feature is the progressive delayed phase enhancement. The lesion can infiltrate or tether the adjacent bowel. MRI will also show both T1 and T2 low signal with delayed contrast enhancement. Next. So this is a round, well-defined desmoid tumor, and we can also see the infiltrating margin of the tumor with the surrounding bowel involvement. Next, please. So this is a table taken from Goran Levin, and in this there is differential diagnosis for mesenteric masses. It can be primary neoplasms or secondary tumors. Primary neoplasm of the mesentery include desmoid tumors, malignant peritoneal mesothelioma, primary peritoneal serous carcinoma, well-differentiated papillary mesothelioma, multicystic peritoneal mesothelioma, desmoplastic round cell tumor, adenomatoid tumor, and secondary tumors include peritoneal carcinomatosis, carcinoid tumor, and lymphoma. Next slide. Next slide, please. Okay, coming to the differentials for bowel masses, malignant bowel tumors, small bowel adenocarcinoma and malignant GIST. They most commonly occur in proximal small bowel. Carcinoid and lymphoma usually occur in the distal small bowel, and metastasis and sarcoma are other rare causes of small bowel malignant neoplasms. Next slide. Coming to carcinoid tumor, the newer terminology is gastroenteropancreatic neuroendocrine tumor. So the distribution, since they arise from the neuroectodermal cells, they can occur anywhere in the body from head to toe. So majority of the neuroendocrine tumors occur in the gastrointestinal tract, then tracheobronchial system, then other rare sites are primary hepatic carcinoid, ovarian, thymic, etc. Then among gastrointestinal tract tumors, small intestine is the most common site, followed by rectum, appendix, stomach, and duodenum. Previous slide, please. Okay, next slide. Next slide. So coming to the most common small ileal carcinoma, which is the most common small bowel carcinoid. The primary can be a small tumor in this mucosa or submucosa with significant metastasis in the mesentery with a desmoplastic reaction, and can show lymph nodal or liver metastasis. There can be calcification in 70% of the cases. And 30% of the small intestinal tumors can be multiple also, and 60% can show metastasis at the time of diagnosis. So presentation of the small intestinal ileal carcinoids can be as intussusception, since they can small submucosal or mucosal tumor can act as a lead point. Also, they can infiltrate the vessels and bowel. So we have to look for bowel ischemia and any signs of intestinal obstruction. Majority of the ileal carcinoids are functional. That means since they arise from the enterochromaffin cells, they will secrete serotonin and some other vasoactive peptides into the bloodstream. And if the serotonin can produce fibrosis, which is responsible for the mesenteric retraction and the other speculation. Another a common site for GI carcinoid is the appendix. Usually in appendix, carcinoid occur at the tip of the appendix. Here is one of our cases. The patient was actually diagnosed as clinically diagnosed as acute appendicitis, and on imaging, we incidentally found out this polypoidal mass at the base of appendix, which is seen projecting into the cecum, and it was showing enhancement, and a few calcific foci are also seen within, and it was found to be an appendiceal carcinoid. Next slide. Another rare site of GI carcinoid is the duodenum. This is also our case. Here we can see an enhancing polypoidal lesion at the second part of duodenum, and it shows intense enhancement in the arterial phase. Next slide. So duodenal carcinoids are 2 to 3% of the GI neuroendocrine tumor, and majority are gastrin G cell tumors. They will produce gastrin and can cause Zollinger-Ellison syndrome, and there is an association with multiple endocrine neoplasia 1 and neurofibromatosis 1. Next, please. So gastric carcinoid is a stomach is also an rare site for carcinoid tumor, and in gastric carcinoid it can be of 3 types: type 1, 2, and 3. In type 1, there is an association with chronic atrophic gastritis, and we can see focal or single or multiple small lesions along the wall in the fundus and body of the stomach. This is tumor. Next, please. This is type 2 carcinoid. This type 2 carcinoids are associated with the Zollinger hypergastrinemia associated with the Zollinger-Ellison syndrome in MEN1. We can see the diffusely thickened nodular mucosa of the stomach, and this is polypoidal enhancing lesion representing type 2 gastric carcinoid. Next. Mesenteric carcinoid. Mesenteric carcinoids primaries are very rare. Usually, we get metastatic tumors in the mesentery. This is a typical appearance of the mesenteric carcinoid with oval mass with the stellate appearance due to the radiating fibrous strands, and there is calcification within the mass. The barium follow-through study showing displacement of these small bowel loops due to the mesenteric mass. So carcinoid syndrome. Carcinoid syndrome occurs when a carcinoid tumor secretes certain chemicals into your bloodstream, and it is causing a variety of signs and symptoms. So all carcinoids does not produce carcinoid syndrome. Carcinoid tumor with significant metastasis to liver usually produce symptoms, because that only then only the somatostatin and other vasoactive peptides can bypass the liver metabolism and produce produce their effects. Next slide. The typical carcinoid facies showing cutaneous blushing, venous telangiectasia. Other symptoms include diarrhea, bronchospasm, and cardiac valvular lesions. Usually right-sided valvular lesions are there. Besides the diagnosis, radiology has a role in treatment also. In case of locally advanced disease and high-grade and metastatic tumors, we can reduce the tumor size and extent using lutetium-177 combined octreotide therapy. So lutetium-177 is a low-energy beta emitter, and it is combined with this octreotide because our carcinoid tumor will express or overexpress the somatostatin receptors, that these octreotide lutetium labeled octreotide will bind with the tumor cells and can destroy the tumor cells. Then the role of PET scan. In carcinoid, what is the role for PET CT? Because as I said, this carcinoid tumor expresses somatostatin receptors, mainly somatostatin receptor 2, 3, and 5. So before going to the PET CT, I just telling you the grades. Neuroendocrine tumors can be graded into grade 1, 2, and 3. Grade 1 and 2 are well-differentiated tumors, and 3 is poorly differentiated according to the Ki-67 value. So there is octreotide scan. In this, indium labeled pentoctreotide is used, which has affinity towards somatostatin receptor 2. Now we have better DOTA PET CT scan, in which we use octreotide analogs. We can use DOTA NOC, DOTA TATE, or DOTA TOC. And the DOTA NOC, gallium-68 labeled DOTA NOC is most common. It is used nowadays, and it has affinity to for somatostatin receptor 2, 3, and 5. So it has highest sensitivity and specificity in identifying the tumor. Then DOTA TATE, gallium-68 has highest affinity for receptor 2 and also 5. It is used for well-differentiated neuroendocrine tumors. DOTA TATE is also used in combination with lutetium-177 in the therapeutic aspect. Then FDG PET will has affinity towards high-grade tumors. So we can use in case of grade 3 tumors. Then for grade 2 tumor, we can use both the FDG PET and DOTA scan. That's all. Thank you.
That is a wonderful presentation and wonderful case also, because all the modalities were utilized in this case. And it was treated also. So, and follow-up also was given. Excellent case presentation.
Thank you, ma'am.
So, what was the main symptom of the patient when they came to you? Actually, the first slide I couldn't read. What are the symptoms of this carcinoid was there?
Patient presented with abdominal pain and bloating sensation and altered bowel habits, diarrhea, vomiting. Also, the patient was hypertensive.
It was a really beautiful case. Okay.
Aditi, can you just sum up?
Okay. Aditi, you can ask questions.
I'll ask a few questions.
Yeah.
So Shruti, stay there. So what is Carcinoid Syndrome? What is the constellation of findings in Carcinoid Syndrome?
Carcinoid syndrome occurs when the carcinoid tumor producing vasoactive peptides, serotonin, histamine, and all, when they will reach the bloodstream, it will produce vasospasm and bronchospasm, leading to the clinical presentation. So if you for a carcinoid syndrome to manifest, the peptides have to bypass the liver first. So in case of large tumors, or in case there is liver metastasis, this peptides will be bypassed by the liver deaminase enzymes, and it will be presented as.
And can you mention few syndromes associated with carcinoids?
Okay, as I mentioned earlier, it can be associated with MEN syndrome, multiple endocrine neoplasia, and neurofibromatosis.
Okay, so Zollinger-Ellison syndrome may be associated. So gastric carcinoids are more commonly associated with Zollinger-Ellison, and duodenal carcinoids are more associated with NF1. Okay, then what is carcinoid heart?
Carcinoid?
Heart, cardiac manifestations.
Okay. When the vasoactive peptides bypasses the liver and reaches the right heart, a fibrotic plaque will be deposited in the endocardium, valvular surface, and also the caudate tentina, producing mainly they affect the tricuspid and the pulmonary valves, resulting in mixed stenotic and regurgitative symptoms will be there. Okay, signs and symptoms of TR and TS will be there. Tricuspid stenosis and regurgitation.
So right-sided chambers are affected and left-sided chambers are spared. Why?
So from the circulation, it will reach.
Because the vasoactive peptides, once they reach lungs, they are again detoxified in the lung before they reach left side of heart. So most of the findings are concentrated in the right-sided chambers. Okay. And what about echo? Is echo indicated in every patient with carcinoid?
Only symptomatic.
Symptomatic, and based on anatomic location of carcinoid, can you suggest which
in ovarian or hepatic? Ovarian.
No, actually, carcinoids in gastrointestinal tract can be divided into foregut, midgut, and hindgut carcinoids. So it's the midgut carcinoids that usually produce all the typical features of carcinoid syndrome, because they arise from enterochromaffin cells. They are more commonly associated with the release of serotonin and 5-hydroxyindolacetic acid and all. So it is the midgut carcinoids that are more commonly associated with cardiac manifestation. So, okay, so based on the mid location and based on the serum levels of chromogranin and 5-HIA and natriuretic peptide levels, the patient should be suggested echo accordingly only. Then what will you suggest your technician how to perform a CT if you are suspecting carcinoid? What instructions will you give your technician?
Arterial phase.
Which
early arterial phase.
At what time?
15 seconds after the bolus tracking.
Then regarding the contrast, oral contrast?
Oral contrast can be.
What kind of oral contrast?
Neutral will be better because the enhancing bowel, otherwise it will hide the enhancing bowel mass.
Okay, so oral neutral contrast is preferred, or a CT enteroclysis or enterography with PEG-LEC. Okay, or mannitol, so whatever. Then you have already mentioned about the functional study. So what is the basis of gallium-68 scan? Why do we prefer gallium-68 scan or functional? What is the importance of function? Why functional studies are important in carcinoid?
Because the tumor overexpresses the somatostatin receptors. The uptake and will be more, and the specificity and sensitivity of findings will be more.
That is maximum for gallium-68 scans. Okay, to find the primary as well as to detect all the secondaries. Then is there any importance to the size of the lesion at detection?
Yes, ma'am. Size also, if size is less, we can resect the tumor and the tumor burden can be reduced. If it is bigger lesion, we will maximum reduce the tumor load, control the lesion.
Okay, in certain locations like stomach and appendix, what happens is if the size of the lesion is more than 2 centimeter in stomach, it will go for surgery.
Total or
Otherwise, if
partial.
it's less than 1 centimeter, just endoscopic
Endoscopic
dissection and
dissection
surgery.
is- yes.
Similarly, for appendiceal tumors, if it's more than 2 centimeter, they go for hemicolectomy. If it's less than 1 centimeter, they go for appendicectomy. So you have to make the size is important. And another thing is, as the size increases, the chances of metastasis
more.
also increases. Okay. So what are the complications associated? What are the complications you should rule out? You should exclude, or you should mention in your scan report?
Okay, as these carcinoid tumors can invade the vascular structure, we should inspect. We should look for the bowel ischemia infection, and also look for bowel obstruction, as these tumors can invade the bowel.
Okay, they can act as leading point of intussusception.
Intussusception.
And another thing is they may be associated with synchronous or metachronous tumors. So you have to look for any other second primaries elsewhere. And I think gastrointestinal adenocarcinomas are the most common associated malignancies in carcinoid. Okay, so that has to be, patient has to be followed up. Then another thing is there any role of MRI? So mostly we can make the diagnosis with CT and PET scanning, DOTA scanning. MRI is mainly used to follow up the younger patients who have metastasis because they require long-term follow-up. So T2 weighted imaging in MRI can pick the hepatic lesions very quickly. So mainly MRI is for follow-up. Or if the patient has some reaction towards CT contrast, then we can go for MR enterography or enteroclasis. So, okay, that's all, ma'am. Tara, ma'am.
So I believe that was an excellent session for the PGs covering almost all the topics. And thank you, Dr. Aditi, so much for the nice, excellent tips. And I think, shall I move on to the closing ceremony, ma'am? I think, so I'm thank everyone from the organizing team who have made the session possible. And I thank the PGs who volunteered for the session. And like there were some glitches in between, and I extremely thank the MedPiper team for sorting it out. And so we are closing the session, and I request you all to attend the next session, that is on Saturday. It will be a faculty talk by Dr. Anurita, an expert in the field of GI, and then she'll be talking to us Saturday on post-op bowel complications, and the time would be at 5 p.m. on Saturday. I thank you all once again. I thank the audience and all the participants. Thank you and good night. Thank you, Soumya.
Thank you. Venu, we can close, Dr. Venu?
Yeah.
Dr. Tara, you told
Thank you
about
all.
the certificates. Did you tell about the certificates?
No, ma'am.
Soumya, you can tell. Soumya?
Yeah, so thank you everyone for joining us today for the IRIA Kerala PG Grace presentations on GI. So I have shared the certificate request form in the chat box. So members who would like to receive the participation certificates can, register from there, and we'll be providing the certificates accordingly. Thank you.
Okay.
I know. Yeah.
Good night.
Thank you.
Good night.
Thank you so much. Good night.